we're good to start.
Shall I start, sir? Yeah. So, good evening, everyone. Welcome to our Tuesday masterclass webinar from Department of Critical Care Medicine, Yashoda Hospitals. So, for today's talk, I welcome Dr. Sheila ma'am. So, Madam is very well known across India. She is immediate past president of IDCCM, and she's having almost, I can say, around 200 publications, international and national. So we very enthusiastically follow her eloquence and charisma, I think, command and her passion towards the educating students is, I can say, it's contagious. So many lectures I heard your lectures, ma'am. They are really inspiring, and it simplifies all the whatever the complex material. Always you simplify that, and I think the students grasp it very easily that way. Thank you, ma'am. We are privileged to have you on our platform. Welcome you on board, ma'am.
Thank you very much. It's my honor and great pleasure to be here. Thank you.
Okay. And I welcome Dr. Venkat Raman Kola, sir. None other than he's the mastermind of our regular critical care webinars every Tuesday. Without, I think it is near to 4 years, 3.5 years post-COVID we started. He's the mastermind. And is the driving force behind all of us, who actually his passion is towards teaching is definitely very contagious. And I can say we are lucky to have a clinical director to all our Yashoda hospitals. It's really very honor to have you on board, sir. I welcome you for that.
Thank you. Thank you, Kaladhar.
So today's topic of discussion is sepsis, septic shock, and hemodynamic monitoring. So I welcome our two students, Dr. Cherishmanjali, and she's from Care Hospital Vizag, and Dr. Swathi, she's from Medicover Hospital Vizag. Both are from Vizag. They are IDCCM residents. So I think with that, we will proceed with the discussion. Dr. Cherishmanjali.
Good evening, everyone. I'm Dr. Cherishmanjali from Care Hospital Vizag. Good evening, ma'am. I'm Dr. Swathi, IDCCM Resident from Medicover Hospital, Vizag. Today, we are going to discuss a case about sepsis. A 45-year-old female residing at Visakhapatnam came with the chief complaint of fever since 1 week, abdominal pain since 5 days, vomiting since 5 days, reduced urine output since 1 day.
Do we have any problem there? You can go back to the previous slide. There is some noise issue. Is it to everyone?
Yeah, there was some noise issue, definitely.
Yeah, okay. Okay. Ma'am, we can actually wait with every slide, so you can take that.
Yeah, sure.
Ma'am.
Sure, yeah.
Shall I repeat it again?
Yeah, this
A
is
45-year-old female residing at Visakhapatnam came with the chief complaints of fever since 1 week, abdominal pain since 5 days, vomiting since 5 days, reduced urine output since 1 day. History of presenting illness. History of fever since 1 week. It is acute in onset, high grade, intermittent in nature, associated with chills and rigors, and it is relieved on medication. Fever is not associated with night sweats, and fever is not associated with any rash over the body. History of abdominal pain since 5 days. It is continuous in nature, dull, dragging type of pain in left loin, which is flank region, radiating to the left lower abdomen, associated with nausea and vomiting and reduced appetite, no aggravating and relieving factors. History of vomiting since 5 days, 1 to 2 episodes per day, non-projectile, non-bilious, no aggravating or relieving factors.
right. So if you could just go back to your previous slide. So
Yes,
the chief complaints are fever, abdominal pain, and you talked about vomiting, right? So
Yes,
just from this kind of history, and when you've talked about fever, you've asked some very specific questions. What is a fever? What is the nature? I mean, what is the intensity? What is the nature? Is it relief? So what are you trying to, what are you trying to, what kind of differential diagnosis are you trying to make about the fever, origin of the fever, just from this history related to the nature of the fever?
Yes, high-grade fevers associated with rash, we have to rule out tropical fevers, ma'am. And night sweats usually are tubercular origin, ma'am.
Only tropical with rash?
Ma'am?
I said with rash, is it only tropical infections?
Tropical infections generally will come with rash.
Okay. What about viral infections? Viral is right?
Viral fevers also will come with rash, ma'am.
Okay, okay. Then
Night sweats, tubercular origin, ma'am. Tubercular fevers usually present evening rise of temperature and night sweats, ma'am. And
right.
high
Then,
grade,
yeah, high grade. Yeah, go ahead.
high grade fevers, any infection, like any renal infections or any other infection, cellulitis or anything will cause high grade fevers, ma'am.
Well, not very specific, but okay. But you've asked something else about chills and rigors, right? That's also very important, associated with fever. So can you tell me something about that?
Usually malarial fevers will be associated with chills and rigors, ma'am.
Anything else?
Urinary tract infections can present it with chills and rigors.
Right. Anything else?
Localized infections like abscess.
Also bacteremias. Okay.
Bacteria.
When you
Yeah.
see, especially line-related bacteremias, you'll see a patient can have chills and fever and chills. It's very typical. Yeah.
Yes, ma'am.
Okay. Yeah. Okay, go ahead. So you're talking about abdominal, now just from this much history, okay, vomiting, abdominal pain, and fever. What are you thinking just with these three symptoms that this patient is talking about? What are you thinking just at this point?
Abdominal pain, which is flank to loin, loin to groin pain, is typical of renal origin pain, ma'am. And abdominal pain with vomitings and fever, sepsis. There is infection in the infection in the renal, like the UTI or any history.
Okay, likely, but you can't just clinch the diagnosis from that. Okay. All right. So what would be differentials from an abdominal if you're talking about fever, abdominal pain, and vomiting, right? So more pointing towards something towards the abdomen pelvis. That's the origin of this infection, right? Probably infectious because it's fever. So what could be your, what are you thinking? I don't want to differentiate. I just don't want to think, I don't want to know what you're thinking at this point.
It could be differential diagnosis could be acute gastroenteritis will present with abdominal pain, vomitings, and fever, ma'am.
Okay.
And acute cholecystitis can present with pain, vomitings, fever. Pancreatitis will present with pain, vomitings, and fever, pain, vomitings, ma'am. Female pelvic inflammatory diseases can present with pain, vomitings, and fever.
Right. So there are many things that could be associated with this, right? But of course, you have this pain from the left loin radiating to the lower abdomen. So this is a little more specific. But otherwise, if you just have fever and abdominal pain, then there are many, many differentials that you're thinking about, right? Okay.
So
All right, go ahead. Sorry.
if you actually divide abdomen into the 9 quadrants, which you generally divide, and each quadrant has its differentials, right? And you had specific differentials for this case. You said you have a left loin flank pain radiating to the lower abdominal. What are the differentials other than you said, you used some vague terms, said infection, then you said urinary infection, then you said sepsis. What is specifically you looking at in this case?
Cystite, pylon,
And
renal caliculi, sir.
Renal calculus, do they cause that amount of severe pain radiating down? What are the calculus which causes pain, which are pain sensitive organs?
Liver, renal, liver.
And it is pertaining to left side, can be pyelonephritis or any colitis or any localized abscess. These can be the differentials.
Yeah, so very good. So each quadrant has its own differentials, as you mentioned about the different differentials vaguely. But when you came to this left loin pain, I think those 3 or 4 differentials which I'll take.
Right.
Localized collected Swass abscess or a lumbar or a paraspinal muscle related any inflammation or abscess, or as you rightly pointed out, pyelonephritis, or as you said, any colitis in that area which can cause the pain. But
Right.
as asked you the point that when you are talking about a severe pain causing vomiting, radiating down, and all, it has to be some obstructive renal or ureteric calculi. If it is in pelvis and renal calyceal system, most of the times that doesn't cause such a severe pain if it is not obstructing. Okay, it is something which is obstructing downstairs. As you rightly said, it can be a ureteric calculi or a calculi in the pelvic calyceal system which is obstructing. And because there is a fever and you have other, you are suspecting that obstruction led to some amount of probably infection, which can be a query, as you said, pyelonephritis.
I think, what Dr. Kola said is a very important point. So the nature of the pain. So you have a dull, dragging kind of pain. It's not a shooting, sharp pain. So that can also give you a lot of valuable information about, because sometimes this kind of pain is something unbearable, especially if there's obstruction and associated with this. So the patient would, if you've seen someone with a renal calculi, they just can't, if there's obstruction, they'll be in severe pain. It will not just be a dull, dragging kind of pain. So that itself tells you a lot about what the etiology may be.
Just keeping aside that left loin or the left lower abdomen, if I combine fever, vomiting with abdominal pain, what other differentials you said acute gastroenteritis 1, anything else you're saying?
Cholecystitis.
Okay. Yes.
Pancreatitis.
So all those come. And then you actually uttered 2 words. One, you said urinary tract infection or infection. Then you said sepsis. Probably we'll discuss that in later slide.
Yeah, I just want to ask you one thing. Now, patient might give you this complaint, but you should also rule out from the history. Like you're thinking of other things. It may be appendicitis, it may be anything. So, like Dr. Kola talked about 9 quadrants. So it's important to also rule out that, do you have this? Do you have this? Do you have that? That's also very important because sometimes, it may be a little misleading and it's not very specific with the kind of nature of history that they give you. Whereas here it's more specific, but sometimes it may not be. So it's also very useful when you take your history to rule out that it's not, they don't have any other symptoms that they're not expressing. Yeah. Go ahead.
History of decreased urine output since 1 day. History of burning micturition since 5 days. Associated with increased frequency and urgency and associated with high colored urine. Not associated with blood in urine. No history of loose stools. No history of abdominal distension or yellowish discoloration of eyes. No history of recent weight loss. No history of white discharge. No history of recent travel. No history of chest pain or cough with expectoration or shortness of breath. No history of trauma or recent blood transfusions.
So I think this additional history makes you rule out many things, right? Right? Because you've talked about no loose stools, abdominal distension, you've talked about that. And you've talked more specific about urinary symptoms, right? There's burning, micturition, there's decreased urine output, there's increased frequency. So there is more pointing towards not something in the GI tract, but more likely to be something around of the urinary tract, right? What other information do you get from this history?
We can do no cough with expectations or no respiratory involvement. No? So we can do a fever with vomitings, pneumonia could also be like precipitating. So cough with expectation and shortness of breath will rule out respiratory involvement, ma'am.
Right.
Chest pain and no shortness of breath, cardiac involvement, and abdominal pain is atypically they may present with chest pain. Cardiac.
You mean to say you are trying to exclude a radiating kind of atypical presentation of cardiac origin?
The cardiac involvement also we are excluding.
You are asking about chest pain. See if you are saying that my cardiac pain can also be somewhere in abdomen, sometimes it is a referred pain. So then you will not have chest pain. You will again have this as a referred pain, which can actually trouble you sometimes.
Yes,
so
sir.
in that time, asking about a chest pain will not give you a clue. Probably you'll ask about any history of a CAD or a risk factors, or looking for that will help you. And you are talking about cough, expectoration, shortness of breath is all for a pneumonia to rule out. How do you explain pneumonia causing a right lumbar or a loin pain?
I think she's just talking about it as general, ruling out other symptoms.
So maybe you are saying, see, every time you give a history, it is for an exam. This is for a point. You give some clues, your examiner drags you. That's what I'm trying to learn from this CA. Suppose you actually talk about something, then you have an idea that you're talking about some pneumonic effusion, some pleurisy, some referred pain in that left CP angle somewhere. So you should have a reason when you give you give a travel history, you give a intermediate fever, you are talking about any malaria or something else. So everything you inform or you do an investigation, you give a history. You should have a rationality for that. That's what, ma'am, we actually look for in exam. Whenever you give some information, it has to be a rational.
See, nothing you say is right or wrong, but what Dr. Kola is trying to say is that you have to have a justification that what are you thinking when you're asking for this history, right? That's what he's trying to say. But anyway, from the history that you've taken, it's more specific, it's more pointing towards something, and you're just from the history taking, you're getting an idea as to which direction you're moving in and which systems are likely to be, which system is likely to be involved. Right.
Past history, patient had history of similar complaints in the past and was treated for recurrent urinary tract infection. She had 2 episodes in the last 5 months and she was treated on OP basis for symptomatic relief. Patient is a known case of diabetic since 10 years and hypertensive recently diagnosed since 6 months. Medication history, patient is on tab metformin and glimepiride 1000 mg per 1 mg twice a day and tab vildagliptin 50 mg twice a day and tab telmisartan 20 mg once a day. Patient was non-compliant to medication. Family history is not significant. Personal history, patient takes mixed diet, normal sleep
One
pattern.
slide back. One slide. What is that you're getting information from this slide related to your case?
Poorly controlled diabetic. Patient is poorly controlled diabetic and she had a recurrent history of urinary tract infections previously, sir.
So poor glycemic status, any previous glycemic status of this patient, any previous HbA1c reports, anything which is, the history is only suggesting he's poorly compliant, but any history where there is an evidence that the glycemic status was poor. What does that correlate or importance to your case? Poor glycemic control.
HbA1c report and FBS.
Something like that can give you more information, but I'm asking you if you're saying poorly compliant to the medication and you are assuming that this patient must have had a poor glycemic control. What has that to do with your case?
Recurrent history and poorly in more chance of infections.
So that can lead to more possibility of this patient can be more prone for infection. That's what you're trying to.
Yeah.
And
Just being diabetic and being poorly controlled, of course, increases your risk of infections.
So that will be giving you some lead. And what about the recurrent urinary tract infection? What does it lead to?
See, the same history in a patient who hadn't had this, when you're saying recurrent urinary tract infections, versus someone who's come with these symptoms and has had recurrent urinary tract infections. That's what Dr. Kola is asking. So what are you thinking?
Assuming this patient is not a diabetic, but he repeatedly comes with urinary tract infection. Yes, we do understand female as a urinary tract will have more prone, but assuming if that risk factor is been taken aside. So what are the other possibilities if somebody recurrently comes with a urinary tract infection?
Immunocompromised, obstruction.
Okay, I'm not, so some obstruction, some urinary or a ureteric calculi or a renal calculi, somewhere some obstruction, which can be one reason. Somewhere you can also see any structural issues anywhere on the flow of the tract, which can lead to this kind of recurrent of infections. Okay. So these are the things which actually give you a clue that this patient has been leading to a recurrent infection.
Yeah. So many, like poorly controlled diabetes or some instrumentation or something like that, or some stenting, or something done in the past, or like he's saying, obstruction anyway in the entire system could lead to this kind of recurrent infections.
Picture, renal calculi, any anomalies in the tracts or the ureteric openings, and all this can lead to this kind of propensity or prone for this kind of. Okay, next slide.
Yeah. So even things, have they been admitted for uncontrolled diabetes or any time with any other, this thing? That history is also very important. Previous admissions or any complications related to the diabetes.
Patient had no previous admissions, ma'am. She was on OP basis. She took the medication for symptomatic relief only.
Yeah, because you said
medication history was not known.
Sure.
Patient takes mixed diet and normal sleep pattern, regular bowel habits. She attained menopause, not a smoker and not alcoholic. General examination, moderately built and nourished. Weight 62 kgs, height 154 centimeters. No signs of pallor is present. No signs of icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Tongue is dry and JVP is not raised.
Yeah. See, this, personal history of not an alcoholic is not a very good way of saying it, okay? Not a smoker is okay, but you can say either it does not consume alcohol or occasional consumption, and you can quantify it. But it's not that you're an alcoholic or then you're a non-drinker, so that's not a very good way of saying it. So don't say non-alcoholic. Just drinking doesn't make you an alcoholic. Huh? So you should specify, does not consume alcohol or occasional consumption or whatever, or you quantify it, or a patient may be an alcoholic, then you need to give us some more specific details. Okay.
In this general examination, you said tongue is dry, JVP not raised. What do you mean by these two words?
Dehydration. Patient is like increased thirst, dehydration, tongue is dry.
Is that so? If the patient is tachypneic with some reason, the tongue will be dry. So what are the other features you will look for if I'm really looking if that my patient is dehydrated or volume depleted?
Skin pinch test we can do, sir. And mucous membranes will be dry. Patient will be thirsty and sweating patient will be agitated.
No, I think you are confusing with the hypotension or hypoperfusion to the brain with the dehydration.
That is different from, he's just talking about clinical signs of patient being dehydrated. You look at a patient and you say, this patient looks dry, looks dehydrated.
Sunken eyes.
Okay.
Okay.
Dry skin.
Dry skin.
Mucous membranes will be visibly dry. Tongue will be dry.
Yeah. Sure. Okay. Dr. Kola, are you looking for something else?
Next slide, we'll go to discuss the later.
Yeah.
Patient is drowsy, arousable to verbal commands, obeying commands, occasionally irritable. Glasgow Coma scale is 13/15. Pulse is 120 per minute. All peripheral pulses are felt. Peripheries are warm. Capillary refill time is 4 seconds. Blood pressure is 80/40 mmHg. MAP of 53 mmHg measured in the left arm, supine position. Respiratory rate is 39 per minute. Thoracoabdominal type. Temperature, patient is febrile. It is about 101 degree Fahrenheit. SpO2 is 96% on room air.
So what is your opinion after this slide? You had some opinion at the initial history. Now you have some findings of examination. So what is your opinion?
I mean, is this patient sick? Do you think this patient is?
Yes.
Or do you think, what do you think? Needs urgent attention, or this patient can just...
Patient needs urgent attention.
Okay. And how has this helped you get closer to your diagnosis, or to what is it pointing towards, all this findings on examination?
Patient is in blood pressure is low, so patient is in hypotension. Pulse rate, peripheries are warm, so it is like sepsis. Patient is in septic, febrile, so infection.
Always that warm periphery, is it always that if your peripheries are warm, you're in sepsis, you're in septic shock or whatever?
Usually,
Is it?
In
Initial phases.
there will be
Is that?
vasodilation, distributive shock.
Why is that? Sorry, I can't hear you.
Initial phase of the sepsis, there will be long peripheries and there will be loss of heat due to the vasodilation, peripheral vasodilation. And in the later stages, there will be hypothermia.
Swati, there is some voice issue.
You
Can
have
come
earphones? You
close?
have earphones with you? That
Can't hear very clearly. Yeah. Yeah, you're right. You're saying vasodilation, right?
Yes.
Yeah. So it's a dilatory condition. Yes, you will get warm periphery sometime, but not always. You might have someone with very cold, clammy extremities, right? When a patient in shock. So it's not always that if you're thinking septic shock, this patient will always have warm peripheries. Right. But your patient does anyway. So what else is leading to your helping you clinch your diagnosis even further? What else is telling you?
Yes,
Giving you
Jesus,
some hints.
performance scale is low, like
Can't
sensorium.
hear you actually.
Sensorium, one is GCS, low GCS, dropping GCS from the baseline. Tachycardia is there, and capillary refill time is prolonged.
So what is all this telling you?
So probably shock. Patient is in shock.
Probably. Okay.
Shock.
What is your definition of shock? What is shock?
Reduced tissue or oxygen, tissue perfusion, increase in oxygen consumption and.
So there is an imbalance, right? Yeah.
Yes.
So why do you say this patient is in shock? Now you don't have any labs, you don't have anything. So how do you assess shock just clinically?
Increased perfusion, like one is reduced sensorium, it is reduced perfusion, brain perfusion might be there.
Right.
Cherishmanjali, whenever you're talking, I think the whole voice getting disturbed. I don't know why. And when Swathi is talking, it's reasonably okay, but the voice is still disturbed. Is there any problem there?
Probably two devices. Maybe are you logged in from two devices or something? Yeah.
Is there
No,
any
ma'am.
device?
No,
Swathi,
ma'am.
can you just speak so that we can see whether it is.
All right. So I got the thing about perfusion, but whenever you're clinically assessing a patient in shock, you should talk about the three clinical windows.
So
Okay.
she was talking about the first window. What are the other two windows?
Other two windows. Yeah. So what are the three clinical windows? Sorry?
Urine output.
Urine output. And the third one?
Jesus, urine output and
Sorry?
You have also seen in this case, which is
First line.
periphery.
Yeah. So you can see the patient is drowsy, right?
Drowsy.
Yeah.
drowsy, decrease urine output. The third window, as madam is asking, what is that third window?
Periphery.
It's a
Okay.
neurological window. Okay. So you look, when a patient is drowsy, when a patient has, it can be altered mental status, it can be just drowsiness, it can be irritability. All these are subtle signs of cerebral hypoperfusion. And sometimes you can have a patient who just comes into the unit. It's not so obvious like in this patient where you have specific signs and symptoms. You have abdominal pain, you have radiating pain, you have all this, and you have this specific history. But sometimes it can just be a patient who's, talking irrelevant or drowsy. And these are clinical signs that are pointing towards, could be pointing towards, sepsis and suggestive of hypoperfusion. So the neurological window, the urine output, you already talked about dropping urine output. And now when we talk about tissue, we talk about the skin. So you're talking about, how do you assess the skin? So you're talking about, you said warm peripheries, but you could often have cold, clammy peripheries. You talked about capillary refill time. But is there something else that we can look at in a patient in shock?
Mottling.
Yes, mottling. Okay. We don't see it very well especially in a dark skin patient. It's classic mottling. I have seen a few times. So do you know the grades of mottling? Do you know how mottling is graded?
One pertaining to the knee, man, and up to the upper thigh, it is grade 2, and involving above thigh is grade 3.
Right. And yeah, I don't, sorry, but I don't hear you too well, but I just want to tell you that you should know the grids of mottling. Okay, based on the where it occurs and the extent it's graded. So you can look at the peripheries. They can be called clammy peripheries. You can have mottling. You can have also the capillary refill time. Now, how reliable is the capillary refill time? Can you tell me something about how do you do check the capillary refill time?
We will check in the digits by pressing it against the glass side. Usually process for 3 seconds. We'll up down and
You can come little closer, maybe in
Yes.
Swathi's position. Shift the system towards you because it is too disturbing. We are not able to hear anything from you.
sir,
Yeah,
am I audible, sir?
better. It's better.
Yeah, now it's much better. Yeah, much better. Yeah.
Applying digital pressure for 3 seconds. Usually to be done with a glass slide, and then
How do you interpret it?
if it usually it should be less than 3 seconds, normally. If it is more than 3 seconds, it is
Again,
reduced.
you move the system towards you or the laptop and come closer and talk. Then you can.
Reduced perfusion. If it is more than 3 seconds, then it can be considered like reduced peripheral perfusion.
Yeah, yeah. But again, there's no standardization in the way that you perform it. There are some limitations, okay?
Yes.
And it may be different when different people perform it and not standardized. So that's one of the issues really, but it does give you a very good, if you have someone whose capillary refill time is say 6 seconds, you know that this is, and the other thing is a trend over time and also comparing, from different phases, you can get some very good clinical information. So things like your, temperature, toe to center this thing, and your capillary refill time, mottling, all this is so the skin, the neurological window, and the urinary, looking at the urine output. And what is your normal urine output? How much are you expecting it to be?
More than 0.5 ml per kg per hour.
So if you,
0.5 to 1.
Clinically, if you're assessing this patient, she has all signs of shock. And remember, you have low blood pressure, but what's very important to remember that you might have a normal blood pressure and this patient will still be in shock. Okay, so blood pressure is a very poor marker. It's not a very good marker of your, you can't really use it as a surrogate for your tissue perfusion. Of course, most of the time it's low, but you can have a patient with say 120/80 blood pressure. And if they're drowsy and then they have cold periphery, they have all these clinical signs, and they are still in shock. And that's why it's important to note that. Yeah.
Yes.
All right. So you're saying shock, and what kind of type of shock are you thinking of? That's obvious, isn't it? It's pointing more to septic shock, right? You have fever.
Septic.
Yeah, right. Okay.
How reliable it is the capillary refill time in the current world? How reliably I can take capillary refill time?
Andromeda.
Yeah, right. Andromeda. So what is it used as a clinical surrogate of what?
Lactate levels, serum lactate levels.
Right, so lactate levels. So can you tell me, just broadly, don't tell me the numbers, what are the findings? What was the Andromeda shock 1 study about? And if you are aware of the Andromeda shock 2 study, if you can just tell me just a summary, because you should know about this.
They compared the capillary refill time with the lactate clearance as for improvement for guiding the fluid resuscitation in shock.
Initially,
They have they concluded that capillary refill time is not superior to lactate clearance.
Yeah. It was a non-inferiority study, right? So they were not able to show, it was not superior, and the p-value was not less than 0.05. Probably if they had a few more cases, it may have made a difference. But what is reassuring is with some secondary outpoints, there was some, superiority of doing capillary refill time. And this is really important because not only for resource limited settings, but even otherwise, if it could be a surrogate. And what is the one advantage of capillary refill time over lactates? One real big disadvantage. If I tell you it's 2.5, then it's 2.5. It's 2.5 for you and it's 2.5 for your colleague. But if I tell you capillary fill time is 3 seconds, and then you measure it and you tell me, no, it's 4 seconds. So it's not something that's very, an absolute objective value, right? So there is variability and the method of doing it and no standardization. But what is the one advantage of capillary fill time over looking at lactate?
Dr. Swathi,
It is non-invasive, like we can.
Okay, non-invasive. Anything else?
Dr. Cherishmanjali, just open the door. Dr. Mohan Maharaj is there with the earphones. He will guide you. Meanwhile, Dr. Swathi, you can continue.
Yes, sir.
So definitely you say non-invasive. Yeah,
You can
it's
come closer. Cherishmanjali, you can come closer and answer that.
non-invasive, cheap to do. But other benefit of one advantage of capillary fill time, which you don't have with lactate. Can you tell me?
One second. Sir, can we connect earphones? Sir,
Yeah,
for
yeah, please.
proper, yes.
Yeah, so if you look at the capillary fill time, are you answering or
Yes,
No.
ma'am.
you get the question?
Yes, ma'am.
Yeah. Just the one thing, one advantage, real advantage and a difference with the lactate for capillary fill time.
Like,
So I'll tell you, so this is, it's real time. So what happens is lactate takes more time for clearance, okay?
yes,
It takes time. Whereas your capillary fill time will give you the, whatever you're seeing will be real time. You're getting what I'm saying?
yes,
Like
ma'am.
before, lactates take time to clear. So, you may resuscitate the patient, the value will not come down immediately. Whereas with the capillary refill time, as you're doing your initial resuscitation and as you're monitoring the capillary refill time, this is something which will give you real-time indicator. And that is why if this is really shown to work, then it'll be something really great for us at the bedside and especially in resource-limited settings. And probably that's why Glenn is so passionate about capillary refill time. Are you aware of the Andromeda 2 study?
Sure.
Yeah, I'm aware of what they're doing. They're taking it one step forward. Do you know what they are doing?
No, not sure.
So it's taking it forward again, the same thing comparing with lactate resuscitation, but they're doing individualized. They have an algorithm which they're looking at more individualized resuscitation. So they're looking at fluid administration based on assessing the fluid responsiveness status of the patient, not just liberal or restricted. And they're looking at that and incorporating capillary fill time in the algorithm versus using usual care. So that is what they're doing. Yeah.
You can connect your earphones. What happened? You can connect your earphones.
Yeah.
It will disturb.
Please go ahead. So I think we've got a lot of useful clinical information from looking at the vitals and just the history, right? So far. Okay, go ahead.
Yes.
They're connecting earphones.
Yeah. No issues.
So please, you can just explain, ma'am. To the other students, there are maybe close to 200 students. Please, you can put your inputs, your questions, and other things which can be answered, and you can parallelly also answer. If you have any questions or you have any suggestions, you can actually post in the chat box. Ma'am, you can just mention about the these three peripheral windows and particularly the controversy or the evidence which is evolving related to both
Yeah. So
the capillary
some
and
people are
Andromeda SOC2 trial.
absolutely. So, people are so obsessed with the numbers and values. Even when I take a bedside round and we're talking about shock, the first thing they tell me is the lactate is so much and this is the blood gas and this is, so nobody's really clinical examining. And I like to say these three windows because then it focuses on these three windows, and you don't miss out anything. And, doing just simply looking at a patient in shock may not be very early in shock where they may be very vasodilated, but you may, just looking at the peripheries, when you're looking at the peripheries, if you're even feeling, say, the toes, and sometimes you see the patient is cold up to mid-thigh, and you can actually, take a pen and draw a line. And you can actually see as you're resuscitating, especially when you're using dobutamine, if there's cardiac dysfunction, you will actually note that as this patient's, perfusion is, peripheral perfusion is improving, you'll actually see the skin getting, you can actually demarcate a line much lower down, and you can actually feel it with your hands. Clinically, it's very, very evident when the, perfusion improves. So that's something that you can look at. Mottling, of course, not very evident in our patients, but I've seen some patients in very severe shock. And that's why it's very important to expose the patient, look at the limbs, look at the knees, look at the, check for it in mottling. In this severe shock, very, very, hypotension and 1, 2, 3 vasopressors, you will see these kind of findings may often be there. And capillary refill time, of course, is something that is not a new test, but is something that has been brought into our limelight now more because of this Andromeda Shock 1 study. And as I told you, Andromeda 2, our center is a part of Andromeda 2 study. And I'm really excited about this study, because I think this will give, if it works, or even if it is a non-inferiority study, it's not as good, it will be very, very useful in managing patients with sepsis in our kind of setting. And it individualizes the fluid management, which I like very much. So that's something that we're looking forward to. Yeah. And the other thing I want to tell you about neuro, people don't take someone speaking irrelevant or someone a little drowsy. They look for hypotension and they don't call it shock. But someone who's just a little drowsy or even talking irrelevant could be a patient who is in shock, in septic shock, So you have to really, be very vigilant about these clinical signs and symptoms that you see, and they'll all help you clinch the diagnosis. Yeah.
Ma'am, you rightly pointed out related to the skin color, that correlating with the picking up of both your, as you said, mottling, and even it affects capillary refill time. So because one of the centers is yours, Andromeda Shock 2 trial, it may give some addition to our human race and our color also.
Of
Because
course, yeah.
even capillary refill in a fair person to a darkly skinned person, the subjectivity varies. The
Very
way
true.
capillary refill happens in a very fairly person, you can actually see that pink blood color returning back very quickly. Whereas in a dark person, you do it, it's not the same way what you see. Did you say struggled anything in
Yeah,
this?
this is, absolutely right what you're saying, because there's wide variability in the response, and there's also variability in the way the test is done. So there's the biggest limitation is there's no standardization. That's the problem. But I would say that when you see it over time, you can see a difference in the same patient. Whatever you're observing, it will be different. The time will be shortened, whatever you're seeing. So that's why, a trend is very, very important. I would say till you have a standardization and you're able to look at capillary refill time. People are doing studies in different races in different regions and trying to see if there are any variations. But definitely the trend in the same person over time is very visible. So that is something at least we can use for now.
So welcome you both back. So you had a differentials and diagnosis at that time, having a query of a infection, sepsis. What do you think now? Please go ahead, Dr. Swathi and Cherishmanjali.
It is a urosepsis with septic shock.
Why you think
Poorly.
Hey, urosepsis.
why
Already made
you think it is sepsis?
Can you confirm sepsis by just because the patient is in shock?
So you're suspecting urosepsis, right? Why are you saying urosepsis? Why it is not just a urine infection? Why you are saying it is a urosepsis or a sepsis?
Patient is tachypneic. The heart rate is more than, like tachycardia is present, and shock is present. Reduced urine output.
How you define, ma'am? You can take over. How would they define? Dr. Cherishmanjali, you can start answering, because I think we are not able to hear properly from Dr. Swathi. So how do you define sepsis in this case? Ma'am, you can take over.
Yeah, so of course the definitions are all there, but the thing is, you cannot make a diagnosis. It's likely to be septic shock, right? But you can't. You have to have evidence of infection, right? So we don't have. All we have is fever, and we also have some organ-specific signs and symptoms that tell us, which is pointing to the urinary tract, right? So,
Yes.
it's likely to be septic shock, and the origin is likely to be, it's likely to be, the site is likely to be, but you cannot say, you cannot confirm the diagnosis. It's not a confirmed diagnosis, right?
Yes.
So, yeah. So,
But
that's-
why are you saying sepsis in this case? It's not, why is not an infection and sepsis? You're saying sepsis.
is it just something straightforward? You told me yourself that this patient is very sick, right?
Yes, ma'am.
So why is that?
Systolic BP is less than 19 and respiratory
Don't
rate
go by
is
blood pressure. Like I told you, blood pressure is a very poor marker. We talked about it.
patient is having tachypnea rate is respiratory rate is more than 39. Patient is febrile and tissue perfusion is low. Capillary refill time is more than 4 and patient is drowsy. So based on immediately assessment based on the SOFA Q-SOFA score, it is more than 2.
So what is the relevance of Q-SOFA in your institution or emergency room or an ICU right now? What is the things went on with the Q-SOFA? So what exactly Q-SOFA reflects?
So what are the three things what are the things you look for in QSOFA? What is QSOFA rather? And how reliable it is, and what is the current thinking with QSOFA?
Respiratory rate, systolic BP and GCS, ma'am.
Good.
Very good, yeah. So what are the limitation of QSOFA? Because at one time QSOFA was very popular, and then the sepsis 3 definitions we had. What is the limitation of this? You're looking at just 3 parameters, now. You said respiratory rate, you talked about what else?
Systolic BP, GCS and respiratory rate.
Yeah. So what are the limitations of what is QSOFA used for?
Yes, ICU admission for ICU admission.
Is it for ICU admission?
More than 2 needs immediate.
It's like a quick screening, isn't it? Okay,
Quick
that's
screening,
your
yes.
admission. But what are the limitations of this QSOFA? It's used for sepsis, isn't it?
Other organs are not like it is taking into consideration only GCS and respiratory rate and BP and circulation and lungs and breathing. Other organs are not considered taken into
It's
consideration.
used for assessing your severity, right? And as a
Yes.
screening process, isn't it?
Yes.
Yeah. You might land up picking up a lot of patients who don't have sepsis actually when you use the scoring, right?
Yes.
Specific for sepsis, someone who's got a tachypneic and just it may not be sepsis, right? So it's basically a screening tool for sepsis, isn't it? Yeah. That was one of the limitations of this, that you will overdiagnose if you, but of course you won't miss patients who may getting sick.
What are the other scoring systems which has been considered in these setups when you don't even have labs and other things alternative to Q-SOFA?
SOFA score and Apache 2 mu score.
Yeah, so SOFA and Apache will come once your labs come, but this is a
Yes, ma'am.
examination and vitals at this point of time. What other scores we can use? You said mu score. What is mu score?
Use
Modified early warning signs.
So modified early warning signs can give you an alternative, because we have realized with the current available data, Q-SOFA can be poorly sensitive. It can predict probably a sicker group of patients, or can predict your high mortality, which these patients which can be cohorted, but it's a poorly sensitive, and even specificity is also not been good. So the alternative scores, what were the previous score which you used to use, or previous before the Q-SOFA, the other scores which were used, or the other parameters which are used is SIRS scoring system, systemic response syndrome. Now from there we move to Q-SOFA. Now again we are moving to a mu system. So I was asking the same question. In the interest of time, I'm trying to say the difference between a simple urinary tract infection and probably you're saying urosepsis is that when you have involvement of your organ dysfunction, suspicion, which you're suspecting, because now you have not confirmed, as Madam rightly pointed out, you're suspecting because of fever and urinary tract related symptoms that this patient has a sepsis because they of your organ dysfunction. So the organ dysfunction we are now talking about from clinical examination. What are the 3 organs we are talking about? One is before that.
Sorry.
CNS.
Yeah, altered sensorium, CNS as one window.
Especially tachypneic, you said now.
Respiratory and cardiovascular system.
Respiratory cardiovascular system, and the other one is
Urinary
tract, urinary output as a renal function.
Yes.
So at this point of time, you have already you're pointing out towards a multiple organ. Now you have been repeatedly talking about SOC. Madam was pointing blood pressure may not be an indicator, but the organ perfusions or the windows may be appropriate. Suppose this patient whose blood pressure is 80/40, I give a couple of liters of fluid. As for the recommendation that the BP becomes 140/70. Will I still label it as a septic? Is the SOC defined before a volume resuscitation or before I consider if the volume is grossly depleted? How do you define SOC then? Sepsis, I told.
Mean arterial pressure we have to see that is it indicates like organ perfusion. Mean arterial pressure more than SPP.
Mean arterial pressure should be more than 65 and serum lactate level should be more than 2. Yes. And they need vasopressor requirement to maintain mean arterial pressure more than 65, sir. And even with adequate fluid therapy, they are not able to maintain.
Yeah, so you should have given fluid, and then despite that, and remember this MAP of 65, no, this is a lot of people think that is the map that you have to use throughout. Remember, this is only for initial resuscitation. That because you have to have, and it's only because they have shown that just based on one study which has shown that mortality is higher in those patients in whom MAP is maintained, the duration of MAP less than 65 is directly, correlates with increased mortality. So it's only during initial resuscitation. After that time, you can individualize because an MAP of 60 may be okay for somebody, and for somebody an MAP of 80 also may not be okay. So you can individualize. So Surviving Sepsis campaign, when they've said 65, people have understood this, that throughout you have to target 65, but it's not like that. Okay.
Next slide.
Systemic examination of the abdomen on inspection. Umbilicus is inverted. All quadrants are moving equally with respiration and no visible scars, pulses or sinuses or any swelling. On palpation, abdomen is soft. Left costovertebral angle tenderness is present. No local rise of temperature. No guarding, rigidity or rebound tenderness, and no palpable organomegaly. On percussion, no shifting dullness or no fluid drill. Auscultation, bowel sounds are heard. Examination of cardiovascular system, no S1, S2 is heard and no murmurs. Respiratory system examination, patient is tachypneic. Bilateral normal vesicular breath sounds are present and no added sounds. Central nervous system, GCS is E4, E3, V4, M6 and no neck stiffness. Bilateral pupils are equally reacting to light and bilateral plantar flexor response is present.
So suppose assuming this patient has some amount of neck stiffness or not there, what can be the other differential in your case?
Meningitis.
So CNS infections should also be under your scanner just because the patient had some history of loin pain or radiating.
Incidentally, yeah. So that's very important because, you also have this history of patient being irritable and patient being drowsy. So, just because things are pointing in one direction doesn't mean that, you should rule out. It should be more the diagnosis of exclusion rather than, that's a very important point Dr. Kola said. Yeah. And that's why a complete thorough systemic examination is very important, even though you're thinking that it is likely to be the, abdomen or genital urinary system.
Okay. Okay, going back to the previous slide. As a critical care fellow or a clinician, can I add some other examination here? You auscultated, you palpated. Nowadays, we are using something else, which has been a standard of care.
Ultrasound focus, point of care ultrasound.
Yeah. So what can you do very quickly with that?
we can check the cardiac status and lung, whether any fluid,
Ultrasound, cardiac ultrasound, and you can even do abdominal ultrasound.
abdominal ultrasound.
Very quickly, yeah. So what will you look for very quickly, if you can tell us?
We'll check for A profile and B profile in lungs, ma'am, and any fluid or any effusions are present, any consolidation.
Always start with the heart because you're talking about a
Heart.
patient in shock, right? So, and remember, having said that, any patient in shock, always look at the heart and the lung, okay? Not just to do a echocardiography, also do a lung ultrasound. Yeah. So what about the heart?
We can check, we'll check for the chamber in the long, we can check for the contractility of the heart, any effusion, any LVOT, we have to check. Pericardial effusion, any pericardial effusion is present.
So this patient is basically in hypotension, low perfusion state. You said low windows. You said what is this diagnosis? You said shock. Assuming you don't have the differentials of in your mind, this can be a urosepsis. So it is only shock. So what kind of things you are expecting if a patient has low blood pressure with low perfusion state? What are the 3-4 things which should come to your mind? Why the patient will have a low perfusion state or low blood pressure?
It can be hypovolemic.
Always remember that when you have a patient in shock, it could be a preload problem, it could be a contractility problem, it could be an afterload problem, okay? So your echocardiography is real time helping you assess this and making you quickly, make a diagnosis that, sometimes you think it's a problem with preload and then you see that there's sepsis-induced myocardial dysfunction and actually there's global hypokinesia and the contractility is very poor and you'll be giving liters and liters of fluid and then you realize that, no, that's not a very good idea. So it's really, really important to do a quick screening to, find out, is it a preload problem? Is it a contractility problem? Is it an afterload problem? Because that's what you're interested in. That's where your focus can really help you in this situation. So from that perspective, what else can you look at?
Cardiogen. Dilation of any cardiac chamber, contractility of the heart.
You can just have
any
ventricles and get in a very severely hypovolemic patient, right? You can your contractility. What else? What else can you look at?
Kissing ventricle.
What else can you look at in the patient in shock? The heart, you can look at the IVC, right?
IVC.
Yeah. So again, remember that the IVC is not very reliable learning spontaneous breathing, but you can tell you, give you valuable information. The diameter correlates with the preload, whereas the respiratory variations correlate with the fluid responsiveness. So if you're looking at just a diameter, it correlates with preload, not preload responsiveness. Okay. But again, with respiratory, when a patient presents like this, and with spontaneous breathing, and especially if he's tachypneic like that, then every breath is going to have a different tidal volume. And therefore, it's not very reliable in spontaneous breathing, but definitely in controlled mechanical ventilation. If this patient was intubated, then it could be more reliable. Yeah. So it's a quick screening that you have to do. And what do you look at the abdomen or in the...
Any free fluid in the abdomen, we can see any gallbladder, we can check, ma'am. Renal bulky kidneys or any abscess. If any abscess is present, we can see. Any calicus.
You may not be an expert at doing a lot of things. So this kind of situation, you should definitely get an ultrasonographer and do a good pelvic ultrasound for this patient, right? Yeah. Unless you're an expert, of course. But I would continue to do that. Yeah. Okay.
Yeah, I think we should not be interpreting all. You can screen them, but I think we invite an expert radiologist to comment on that. Next slide.
Differential diagnosis, renal calculi, urosepsis, acute gastroenteritis, any tropical fevers, pancreatitis, pelvic inflammatory disease.
Any other differentials we are missing in this case? You gave a few clues in the beginning. This patient is a known case of poor glycemic status, abdominal vomiting. Yeah.
Diabetic ketoacidosis.
Why you're saying that?
Poorly controlled diabetes, vomitings, abdominal pain,
Okay, and hypotension can be
Because of?
de dehydration,
how it get dehydrated?
osmotic diuresis.
So
Osmotic
di-
diuresis.
because of hyperglycemic state, the diuresis that lead to diuresis. So
That
it was,
could also be something up in on your cards, right? In a patient who's diabetic, especially someone who's poorly controlled, has been had, these repeated infections in the past.
so that's why I was saying when you say septic shock and you're repeatedly talking about shock, I don't know if this patient had a volume depleted state because of gross dehydration because of osmotic diuresis. I give a couple of liters of fluid, this patient may set normal pressures. And the urinary tract infection may be just a UTI, it's not a urosepsis. So that's why even the definition sticks to that. You should look that the volume has been replaced back. Intravascular volume has been replaced back. Then you actually continue to have a low perfused state. Probably you will define them there as a septic shock. Okay. So you are onto this renal calculi. Probably I will say renal or ureteric calculi because of pain radiating down.
Probably the obstruction causing an infection.
Yes.
Yeah.
So that may be, as you said, pyelonephritis will be on high card to me because you're saying loin pain, radiating down, and fever, hypotension, if at all these are correlated to the UTI. So probably I'll have a bad pyelonephritis. Next slide.
On arrival, airway, breathing, and circulation were assessed. Patient is drowsy, arousable to verbal commands, and obeying commands. Patient was initially on room air. Two wide-bore 18 gauge cannulas were secured in both hands. Foley's catheter is placed for hourly urinary monitoring, and blood and radiological investigations were sent. The investigations we sent are ABG, complete blood picture, renal function test, liver function test, complete urine examination, CRP, blood and urine culture sensitivity, chest X-ray, which is normal, HbA1c, CT abdomen, CT KUB, ECG, sinus tachycardia is present, 2D echo, and GRBS on arrival is 537 at the time of arrival.
Okay, with that GRBS, will your suspicion go high?
Towards diabetic ketoacidosis.
Any other things? I don't have any evidence of ketoacidosis. Anything else with
hyperosmolar hyperglycemic states.
So that can be indifferent. Why CRP in this case?
Patient is febrile and decreased urine output and hypotensive. So to rule out the infective CRP is for inflammation.
Does it rule out infection, CRP?
No.
Because
elevated CRP.
Will you do procalcitonin? Just asking.
Yes, ma'am.
So your CRP can be elevated even when there's just inflammation. It's not necessary to be an infection. Yes. Yeah.
So just for the sake of discussion, I'm saying in every investigation you send in any patient, there has to be a logical rationale for that. And why are you doing? What are you expecting out of it? From ABZ, I can explain till GRBS. But as you said, CRP, it can be a poor marker of inflammation. So you need to have there is nothing wrong if you're doing it, but you should have a reason behind. If you say CRP will give me information related to infection, probably it may not be true always. It can be a non-specific marker of any inflammation anywhere. And as rightly pointed out by ma'am, even procalcitonin may be not be a marker always. It has been shown to have some negative predictive value, useful for de-escalation, but never to predict.
But it can give you some hints. Okay, I just do a procalcitonin, I see it's in hundreds, very, very high. Okay, it can give me some, but it's definitely not used to decide your choice of antimicrobials or anything like that. Only to de-escalate, of course. Yeah.
Okay. Next slide.
2D echo showed no RWMA and good LV systolic function, and grade 1 LV diastolic dysfunction is present. On POCUS, no B lines are present in bilateral lung fields and no free fluid in the abdomen. IVC diameter is 1.6 centimeters and collapsibility is more than 50%, and left kidney is enlarged with echoes in the renal parenchyma.
Yeah. So another way of looking at again the IVC, so something less than 2 centimeters. Again, I told you the diameter correlates with the preload. And this is spontaneous breathing. So you look at the collapsibility index, but it's not very reliable. What's reliable, I told you, is because during inspiration, the IVC distends in controlled mechanical ventilation. So what would you look at in controlled mechanical ventilation? Supposing this patient was very bad, you intubated the patient and was sedated, and now you're looking at the IVC.
Sensibility index.
Yeah. Or you have something called the delta IVC. There are two different, formulae that we have. One is called the delta IVC, or you have the IVC distensibility index. In spontaneous ventilation, of course, you're talking about collapsibility. So one is maximum minus minimum divided by the mean, and the other one is maximum minus minimum divided by the minimum. So 12% and 18% are the cutoff values. Now, what you're looking here is at the respiratory variations of the IVC is what you're looking at. So you're looking at the maximum with inspiration, you're looking at the maximum diameter, minimum diameter, and then you're minusing and dividing by the mean or the minimum. So that's what you're looking at. So a lot of people interchangeably say that, oh, the IVC is diameter is so much. That does not correlate with fluid responsiveness. It only gives you some idea of the preload. Yeah, so it's important to make that distinction. And also remember that when a patient comes with spontaneous breathing and you're looking at the IVC, it's really not very reliable. In fact, among all the tests that you have, the IVC is least reliable, IVC variability. But the good thing about the IVC for us is that if you're familiar with POCUS, it's very quick to establish. If you have a patient who comes in acute circulatory failure, very quickly, without putting in even an arterial IV line or anything, you can very quickly do a quick screening. And it needs minimal training. So that's the real benefit of doing point of care. Using ultrasound for a patient acute circulatory failure. Yeah.
So with this, what is your impression right now with this information? Now you have a POCUS, now you have a 2D echo. We had different differentials for that low blood pressure. I had a different opinion than you, saying just we cannot conclude with just a fever and hypotension. It is a septic shock. So with this information, what is your inference?
Patient is dehydrated, collapsible IVC.
Volume status.
Hypovolemia.
Patient is hypovolemic.
Yeah, so again, your diameter will tell you about your volume status, whereas your collapsibility will tell you about your fluid responsiveness. Yeah, the two distinct entities that we are looking at. Okay.
So what do you think with the diameter? Is the patient volume status is high, low, normal?
What is normal? What is normal when you say hypervolemia? It's usually more than about 2.2 is what you're looking at. Yeah.
1.5 to 2 is normal.
Yeah.
1.5 to 2 centimeters is normal range. Below 1.5 weight is
We say this patient is in shock, the preload is low, and the patient is likely to be fluid responsive, right?
So there is some amount of hypovolemia, which is one possibility in this. And anything else with this information of your POCUS? Kidneys are enlarged with internal echoes, renal parenchyma.
bulky kidney source of infection. Maybe it can be a pyelonephritis, source of infection.
We are not able to hear you, Swathi. If you're speaking from there, either you come closer or one of
it can be pyelonephritis, left side bulky kidney on focus, maybe due to it can be due to hydroerythronephrosis or pyelonephritis.
Okay.
Yeah.
Next slide.
That will point more towards what is the source. But again, coming to from a hemodynamic standpoint, when you're doing POCUS and you're doing echocardiography, See, you're seeing that the LV function is very good. There's no diastolic dysfunction. If there was diastolic dysfunction, then I would be more cautious about giving fluid to this patient. The other important thing is you've done a lung ultrasound and you're seeing that there are no B lines. So all this is very important. You know, when you decide to give fluid to a patient, of course, not during initial resuscitation. First, the patient, I always say that you should have yes to these 3 points. First, the patient should be in acute circulatory failure. So you agree this patient is in acute circulatory failure?
Yes, yes,
Right?
yes.
Okay. Second is the patient should be fluid responsive. Okay. And here this patient has more than 50% collapsibility or whatever it is you're finding. So it's likely to be a fluid responder. Okay. And the third, which is very, very important, is that even if you're a fluid responder, there should be no risk of giving fluid. So that you are doing by doing a lung ultrasound. You're also doing the echocardiography. Now, the same thing in a patient with very bad ARDS and very bad lungs, even if he's a fluid responder, I would not give fluid to this patient. Or if I did echocardiography and the ejection fraction was only 10 or 20%, even though the patient is a fluid responder, I would not give fluid to this patient. So being fluid responsive is just a test to see that. What do you mean when you say a patient is fluid responsive? What do you mean? Is fluid responsive?
Increase in cardiac output, stroke volume by more than 10%.
Is the stroke volume or the cardiac output by about 15%? So doing these tests only tells you that will the cardiac output increase or not, or the stroke volume increase or not. It does not mean that because you're a fluid responder, you need to give fluid to the patient. You need to be in acute circulatory failure, and you also should not have any risk. So whatever you've done now, the ultrasound as well, lung ultrasound as well as the echocardiography, is kind of giving you a safe zone that, okay, this patient is a fluid responder, and I don't have significant risks for giving fluid. So it's always a balance between the risk of giving fluid versus not giving fluid to this patient, right?
Yes, ma'am.
Okay, next slide.
ABG at the time of arrival, it shows high anion gap metabolic acidosis with the compensatory respiratory alkalosis.
What are the other causes of high anion gap metabolic acidosis?
Methanol poisoning, lactic acidosis, uremia, and diabetic ketoacidosis, and alcoholic ketoacidosis, and salicylate poisoning.
Okay.
So do you expect this patient's pH to be so bad? This almost looks like a peri-arrest ABG.
Yeah, this is not consistent with life, no? This kind of 6
So
point.
do you think, is it a sepsis patient with, suppose a patient with a severe sepsis with organ failures comes with this pH? Will you see that patient so stable, just a GCS of 13, 14? So this ABG is not consistent with sepsis alone. Your pH is 6.8.
Very sick patient. This patient is unlikely
What
to.
are the causes you're thinking about this high anion gap metabolic acidosis in this case?
In this patient, we're thinking of diabetic ketoacidosis.
Alone or something else also is there?
Along with high anion gap, there is non-anion gap metabolic acidosis also underlying in this.
So for high anion gap metabolic acidosis, other than ketoacidosis, do you have any other
Lactic
acidosis?
lactic acidosis.
So will you be doing, given a choice with this all examination at the initial point, like you have said the GRBS, because you have sent the rest of the investigation, you have done an ABG, you have done a GRBS. Can I do some quick test to confirm that?
Urine ketones.
Urine ketones can be done.
Can I add a urine ketones to my testing system?
Yes, sir.
Yes, of course.
So if my urine ketones in the bedside with a strip of test in a minute time, much before your ABG, you will give a clue that if it is 4+ or a 3+, you know it is a DKA case. Okay. And again, I'm not saying it is alone a DKA because you have some other signals also. So at this point of time, I'm still not convinced whether it is a DKA related dehydration
Septic shock related.
or it is septic shock. There is an infection, but is that led to all this complication, or it is a combination of both which has caused that?
Yeah, it could have been triggered by the infection also, right? This
most commonly happens in that same way.
Yeah.
It's the most common combination. Your decay is triggered by some amount of infection or sepsis somewhere.
The other thing I want to tell you, which I missed telling you in the beginning, because when you were presenting the case initially itself, you were kind of clinching, pointing towards the diagnosis. So, don't move in that direction because you kept on saying urinary system, So when you're presenting a case, the examiner shouldn't get the impression that you already know the diagnosis, like when you were initially only talking about the history, always move towards differential diagnosis and could be this, I'm ruling out this, ruling out this, ruling out this, and hence I think it is this. Yeah.
Okay.
So exam is all about it. The cases are known to you. The case sheet is open to you. The diagnosis is known to you.
Exactly.
But it is the approach in which you are appearing. So what both the Professor Sheila, Myatra ma'am and me are trying to do you is giving you the way you approach a case when a case presents to you in this way. What are the possibilities, how you investigate, how you evaluate, how you differentiate from one another so that you can come to a conclusion. So it is very simple and clear that in the beginning you had a decreased urine output, some loin pain. So you know that. But what are the other possible add-on problems can happen to this case where the other add-on things which you are trying to differentiate? This case, you may have one area saying urosepsis pyelonephritis. The examiner may ask, it's not a pyelonephritis. Let me stop there. I will say there is a big Swass abscess. There is a lumbar abscess. I want you to talk about that line. So they can take you anywhere from that point of time. So as ma'am said, don't get fixed by just information given and carry that way. Keep your mind open. Keep on discussing all the possibilities, differentiating from one another. Take the case.
Give your differentials and talk about why it is not that, why you think it's not that, and why you're narrowing it down rather than, in the beginning itself, you were going about urinary tract, you know that you already know what the, condition is. So avoid doing that, talk about, keep it broad till you're moving more. And then finally with the investigations and the imaging and all, you're clinching the diagnosis. Yeah. Okay.
Please.
Seeing that this patient is very, very sick, right? If they got a pH of 6.181, it's a really sick patient, right?
So Dr. Swathi and Cherishmanjali, if this patient is not a DKA, probably unlikely this patient will reach to the ICU from ER also. But if this patient is suspected to have a DKA, what are the possibility this patient will get better?
Possibility to get better.
Fluid viscosity.
So we see just a volume replacement makes the pH in no time to a normal state if this patient is a DKA. But if a lactic acidotic patient with a 25 lactates, my pH is 6.8, most likely this patient chances of survival for few more hours is also, as ma'am said, incompatible with life.
It's not impossible. We've seen some very sick patients, but you have to be very aggressive with your resuscitation. And you can't be, very laid back. Recently, we had a patient similar like 6.9 with lactates of 17. And we were very, very aggressive with this patient. Again, it depends on the type of patient. What is the age of the patient? What are the comorbidities? All that also makes a difference. But you have to be very aggressive if you have someone who's so sick. So you've talked about resuscitation with fluids. So how much, so you're thinking this is septic shock, right? You're moving more towards septic shock. So how much volume do you give initially?
30.
Sorry?
30 ml per kg in initial 3 hours.
What? Colloids, crystalloids?
Balanced salt solution.
Just
crystalloids.
crystalloids will be good.
Yeah, crystalloids, right? We'll talk about balanced salt later. Right. So then, so what is the recommendation? Do you know what the recommendation is? And what is the level of evidence?
Low quality of evidence and weak recommendation.
So, no, but what is the recommendation? Give what? How much? 30 ml?
What IV fluid? What
30 ml per kg body weight in initial 3 hours of presentation.
It's 30 ml per kg and it's over 3 hours, okay? So this is probably one of the most controversial recommendations of the Surviving Sepsis Campaign guidelines, because the 3 hours is it's not only the volume, the 3 hours is a very long duration. You don't give fluid and then assess your patient after 3 hours, okay? You will obviously be assessing your patient more frequently, especially if the patient is so sick. So one of the ways of individualizing this that have been, published is that you can give a smaller volume if you're cautious, especially if I'm doing ultrasound and I'm seeing that I have some worry about this patient. See, giving the same amount of fluid to a young boy with no comorbidities is not the same as giving it to an elderly man with, say, cardiac dysfunction and renal dysfunction. Okay, this is two completely. That's why you can't have a one size fits all approach. So if you want to individualize, what you could do is you could give, say, 10 ml per kg to this patient. You can give it over, a half an hour to 1 hour, and then you can assess and you can see. Now, if you see the patient is desaturating or the patient's, getting worse, then you can probably, consider stop giving the fluid. Or if you see that clinical signs of shock are persistent and there was improvement in blood pressure with that, then clinically, just looking at him clinically, you can continue to give the remaining. So maybe it's not 30, maybe you need to give 40 or 50 or even more, but you could individualize by reassessing after some time rather than, because it's over 3 hours, right? So that's ways that is recommended to, individualize.
Any reason normal saline has been preferred? Is it your common practice or any reason?
Balance.
So you said if you use crystalloid, you would use normal saline.
No,
Balance
without it, 0.9% normal saline given in the
Balance. So what, I don't want to talk about the trials, but what's the evidence? Is there really strong evidence that you should use balanced salt solutions? Do you have any evidence for that? Sorry? So I would say, without talking about the trials, I would say that it's not that normal saline is out. Unlike in the Western world where they're using, especially North America, where they use high volumes of normal saline for resuscitation. That was never the practice in the Indian subcontinent. What is your worry with giving large volumes of normal saline?
Hyperchloremic metabolic stress.
So, and then giving an occasional pint of saline it's not that you never use saline. And that should not be the message. And even when you use saline, you're of course monitoring the chloride levels and looking at the sodium levels. So it's not an absolute no-no, and we should never use saline and throw it out the window. Now, balanced salt solutions, of course, are going to have their advantages, but they are also expensive. But remember, even Ringer's lactate or Hartmann solution is also a balanced salt solution. Okay, so even that can be used, and pretty much Ringer lactate is what people were using for the for resuscitation, right? So you could use either. So it's nothing that you can't use this and you can only use this. It has to be a balanced approach, but definitely colloids, at least in the intensive care, arena, should be avoided. If at all you use colloid, what colloid will you use? Which one?
Albumin.
Yes, albumin. And when will you use albumin?
The initial resuscitation fluid crossed more than 2 liters. Still patient is still not responding, requiring more than 2 liters of
Is it
crystalloid fluid.
2 liters? Is there something like that? Yeah. So as a resuscitation, of course, albumin has many beneficial effects in patients with sepsis. But other than that, typically the kind of patient in which you would consider is a patient you give is requiring, like you said, large volumes of fluid, leaky capillaries, or you give, typically you give a lot of fluid, you see the blood pressure coming up, and again, the blood pressure drops. And you give more fluid and the blood pressure comes up. So he's not able to retain the pressure. This is the kind of patient in which you could consider, giving albumin to this patient. Yeah.
Yes, ma'am.
Otherwise, it will be very expensive to just resuscitate purely with albumin, unless you're in Australia or something like that. Okay.
Go ahead.
Resuscitation is started with IV fluids, crystalloids, 1000 ml of 0.9% normal saline given in the first hour in bolus doses of 250 ml. Urine output is 20 ml for the first hour. It is high colored. Simultaneously, injection noradrenaline infusion is started 0.1 microgram per kg per minute, and right IGV central line and arterial line is placed. Patient was started on HFNO support after 2 hours of initial fluid resuscitation as patient is still tachypneic. Hourly blood sugar monitoring is done, and total 3 liters of fluids were given in the ER, and antibiotic injection meropenem 2 gram IV loading dose is given, and injection pantoprazole 40 mg IV stat is given, and human actapid infusion is started according to 0.1 unit per kg per hour, that is 6 ml per hour.
Right. So I just want to ask you, you started vasopressor. So rightly, your vasopressor of choice, of course, noradrenaline is the one that is preferred, especially in septic shock. So what is your rationale for starting noradrenaline? Why didn't you just give more fluid to this patient?
To maintain the Map more than 65 for diastolic to maintain the diastolic fillings, ma'am. If
So can I just not
coronary,
can I just not give more fluid? How do I decide that I should start noradrenaline? When to start? So do you give fluid first, or do you give norepinephrine first, or should you start both, co-administer both? When do you decide on co-administration? I'm just saying, it was very arbitrary the way the people practice, right? So are there some hemodynamic assessment cues that give you an indication that, okay, I need to start norepinephrine immediately, or I can wait and give some more fluid, right? So is there anything that you consider before starting norepinephrine? Anything that you look at from the hemodynamic variables? Anybody?
heart rate.
Heart rate is not very specific. You know that a heart rate can be, there can be tachycardia because of many reasons, even non-hemodynamic, right? Yeah.
Ma'am.
So
May
you're
not-
saying the heart rate is, you consider giving norepinephrine based on heart rate?
Mean
Mean
arterial
arterial
pressure. Mean arterial
Yeah.
pressure.
Sure. Really? So I can bring up the MAP by giving more fluid. This patient is very fluid responsive. I would give liters and liters of fluid to this patient. Right? So, you want to answer, or do you want me to?
Please, ma'am, please go ahead.
No, so it's very important because it's very arbitrary the way we give fluid, our decision to give vasopressors. It's very arbitrary. And you have to have a scientific rationale for that. Of course, 99%, more than 90% of the patient, any patient who comes in acute circulatory failure, they're likely to be fluid responders. Okay, even the normal human heart is fluid responsive. So no harm. Your initial approach, of course, should be to give some fluid to this patient. May not be 30 ml per kg, but, and you know that sepsis is, it's a distributive shock. It's a vasodilatory shock. And remember, the cardiac output increases to maintain this, to compensate. It's not that, so in patients with sepsis, you might find, the cardiac output may be 10 liters or 15 liters or whatever. And that may also be inadequate. So it's basically the heart that is trying to compensate for this vasodilatation that you see, right? So you get very high cardiac output states. Of course, sometimes in late shock, this might be just the opposite and your output may be very low. But coming back to the fluid resuscitation that you're giving, now, initially you start with fluid. And then I told you after, say, even if you're giving 30 mils per kg, you're giving some fluid. And then to decide whether you subsequently give more fluid or not, it's not very wise to just go on and on giving fluid, because you should give fluid only to a fluid responder. And like you rightly said, a fluid responder is someone whose cardiac output will increase more than 15%. And you can very quickly, even using ultrasound or any of the other tests, you can quickly assess whether this patient is a fluid responder. Now, you don't need to assess fluid responsiveness when a patient initially presents to you with this kind of, severe metabolic acidosis, elevated lactate, and in shock. Of course, you give fluid. You don't need to assess fluid responsiveness status. But once you've given a large amount of fluid, then you need to assess whether the patient is a fluid responder or not. So what is the disadvantage of giving fluid to a non-responder? Yeah.
There'll be no overload. There'll be pulmonary
Overload, pulmonary demand. Yeah. So firstly, there's no benefit. Okay. So when you say someone is a fluid responder, it means the cardiac output is going to increase. You give fluid to increase the cardiac output, to improve the perfusion and improve the oxygenation, right? That's your end goal. So giving fluid to a non-responder is not beneficial because it's not serving your purpose of increasing the stroke volume, and it might actually produce harm. Okay. So just giving fluid is of no use to a patient if he's not a responder. So beyond the initial resuscitation, you shouldn't give fluid to a patient who's not a fluid responder, and you should do one of the tests to assess fluid responsiveness. Now, while you're fluid resuscitating, which are the patients in which you consider giving vasopressors early, or what we call co-administration? So sometimes I give fluid and the vasopressor simultaneously. Okay. Or you might start some fluid and then you might consider. So there are 3 conditions in which you do this. Okay. So the first is if there's life-threatening hypotension. Okay. My patient comes with a blood pressure of 60. I'm going to take a very long time to give a lot of volume to bring that blood pressure up. So you could co-administer vasopressors to this patient, right? The second situation where I will consider giving vasopressors or co-administrating is when there's a risk of giving fluid to this patient. Okay, like I said, a very patient has a very weak heart. I don't want to give large volumes of fluid, so I'll start vasopressors early. And which is another situation? Can you tell me the third situation where you can give vasopressors early? You should start vasopressors early. Can you tell me? Can you think of something? So I told you first when there's life-threatening hypotension. Okay, the second is when there's a risk of giving large amount of fluid to this patient, some medical condition. And third, anybody on the chat, anybody can tell me some situation where you should consider giving vasopressors very early. Anybody? I can't read the chat, sorry. The answer's coming. Dr. Kola, is there any answer coming?
Yeah, I think.
Yes, ma'am.
Traumatic brain injury.
Well, we said trauma. Yes, someone has written, is that diastolic blood pressure? Okay, very smart. Yeah, so it is the diastolic blood pressure. So you kept talking about mean blood pressure. So you look at the diastolic blood pressure. When the diastolic blood pressure is low, this is a very vasodilated patient, right? So you might have the same mean arterial pressure, but the hemodynamic status is not the same. So it's very important when you're resuscitating, look at the diastolic blood pressure. You see the diastolic blood pressure below 45, this is a very vasodilated patient. So when I see the same patient with the same MAP, but the diastolic pressure is higher, say 50, versus the same MAP and the patient with the diastolic pressure, say 35, that's the patient I will start vasopressors on. Right? So these are the three situations where you will start vasopressors upfront, even while you're fluid resuscitating. Otherwise, it's reasonable to give fluid and to give more fluid if the patient is fluid responsive, and then, start vasopressors. Suppose your blood pressure, what else can you give this patient? Supposing the blood pressure is still not coming up, you're giving a lot of fluid, patient not fluid responsive, and you've given norepinephrine. Now, what else could you do? Any other drug you could start?
Can I add vasopressin to it?
Why do you give vasopressin in sepsis? Patients have septic shock. Dr. Kola, it's okay if I discuss this, no?
Yeah, ma'am. Please.
Yeah. So why do we give vasopressin in septic shock? And why do we have a fixed dose? We don't give norepinephrine as a fixed dose,
They
right?
act on different receptors. Vasopressin act on different receptor action.
Okay. No, but is that the reason why do we give vasopressin in septic shock? Specific to septic.
Vasodilation.
So I am giving norepinephrine, no? I'm giving a vasopressor. So anybody can give me the answer in the chat? I can't.
No, I think there is no answer yet.
Yeah. So you have
dose of
vasopressin.
vasopressin has been recommended in septic shock patients.
So you have vasopressin depletion in sepsis, right? And that is why we supplement vasopressin, and that's the reason we give a fixed dose of vasopressin, right? We don't give vasopressin the way we give norepinephrine. But having said that, it's also a vasopressor. So you shouldn't, when you're de-escalating or stopping or whatever, you can't just stop it. You have to, so it's always reasonable to titrate it down rather than this thing. But when you give it a fixed dose. So what is the recommendation for adding vasopressin? When do you do it and in which conditions? So my blood pressure is still low. I've already given a lot of fluid. Patient is not a fluid responder, and I'm on norepinephrine, and the blood pressure is still low. So in which condition should when should I consider vasopressin? Can you tell me what the current recommendations are?
And the noradrenaline requirement increases more than 0.5 microgram per kg, right? Then it is recommended to add second vasopressor.
And also when you have rapidly increasing requirement of norepinephrine, you're starting with a particular dose and it's just rapidly increasing. Okay, these are the patients in which we should consider starting vasopressin early, and also you could consider adding steroid, of course, to these patients, either a fixed continuous infusion, or you could give like 50 QID or whatever regimen. But again, the evidence is low at the moment for doing that. Yeah. Okay, let's go ahead.
Currently, if suppose you have started noradrenaline, you're increasing the dose of noradrenaline, added vasopressin in a fixed dose, still the patient blood pressure is not improving, what will be your second line of vasopressor to add?
Adrenaline infusion.
Yeah, so if you see adrenaline can be used, as an alternative if you see that it's not working. But see, more importantly, when you have the two things I see, very patient on very high dose of vasopressors, when you see that, you must actually question, is this patient a fluid responder? Okay, because often people just go up, up, up on the vasopressor dose, but the patient is actually fluid responsive. And you'll see you give some fluid and the vasopressor doses. They say, oh, patient on very high dose of norepinephrine, vasopressin, I'm trying to think, start methylene blue and this and that. But, often they miss that this patient is a fluid responder. And that's why it's very important to assess fluid responsiveness. And often when I see this on very high dose, I always assess fluid responsiveness. And it's really very, very important to look at this, at the bedside. Yeah.
Oh, yeah, please go ahead.
Patient is resuscitated at the rate of 125 ml per hour with ringer lactate for 4 hours, and urine output is maintained at 40 ml per hour. Blood pressure improved to 110 by 70 mmHg, and the heart rate is improved to 100 per minute. And patient was noradrenaline dose was tapered to 0.08 micrograms per kg per minute, and actrapid infusion is tapered according to the GRBS scale. It is at 4 ml per hour. And APG showed high anion gap metabolic acidosis with compensatory respiratory alkalosis, but lactate levels reduced and anion gap also reduced, but still it is high. Bicarb is improved to 8.
So with resuscitation and, hemodynamic optimization, your patient has done better. pH 7.13. He was really, really sick, almost like Dr. Kola said, peri-arrest. Now you've talked about lactates over here, okay? So what is your goal, really, when you're resuscitating these patients? What is your goal? What is your end goal? What are you trying to achieve?
20 lactate clearance we have to clearance of lactate.
Normal lactate values.
No, less than 2 millimoles per hour.
Millimoles. Okay, so you're looking at lactate. There's another parameter that you could use, which is not in the surviving sepsis campaign guideline, but it can give you some important information, especially when the values are very low. Do you know what that is? The SCVO2. The SCVO2.
SVO.
You already have a central line, I think, for this patient. So you can do, and it can give you useful information. I'll tell you in two areas. So one is you could do a VBG, you can look at the SCVO2. And what does the SCVO2 tell you?
Oxygen extraction.
Yeah, so it is like the balance between the delivery and the, and consumption, right? So you can normally, for example, if I'm giving 1000 ml of oxygen per minute and the consumption is 250, then what comes in the return is 750. So I would expect, so we use SCVO2, but actually what you're trying to use it as a surrogate for the mixed venous oxygen saturation, that is SVO2. But the thing is that they parallel each other quite well. And that's why we use it as a surrogate with a difference of only about 5, right? So we could use the SCVO2. Now, the 3 trials that have compared, SCVO2 and, the early goal-directed therapy and the reverse. I don't want to go into that. And actually showed that there is no difference whether you follow early goal-directed therapy. And that's after this, the SCVO2 came out with surviving sepsis campaign guidelines. But I'd like to say that if your values are very low, especially in our kind of settings, it tells you that the patient is really, really very sick. If you get low SCVO2 values, like you saw in the reverse study, because that was a poor part of America, where the patients presented very late to the emergency department. So they are pretty much the kind of patients which we have, which present like this patient coming with the first blood gas 6.839 or whatever you had. So they're very, very sick and they present very late. So when you do SCVO2 and you have very low value, it can give you an indication that this patient is really in trouble and very sick. Now, in sepsis, what can you get with the SCVO2? You can get very high values, right? And why does that happen?
Hyperdynamic circulation.
Yeah, because of hyperdynamic. So you can sometimes get values like 80, 90, and that can make you give you a false sense of security, that the SCVO2 is very good. And why does that happen? Anybody on the chat?
The causes for very high SCVO2. And
quite seen in sepsis.
Yes. both extremes. We see either a low SCVO2 or a very high SCVO2.
So when it's a low SCVO2, it's fine, but you get a high SCVO2 because of poor extraction. Okay. So, and this is typically seen in sepsis.
Poor
So there's
perfusion,
poor option
cytotoxicity.
extraction. So
Ma'am.
that is not, there's still tissue hypoperfusion. You understand what I'm saying? The problem is the extraction. So you're giving 1,000 and very high is coming on the return. And this is because of the
No
poor extraction. And the tissues are still hypoxia, there's still tissue hypoxia. You understand what I'm saying? So that is why it's very important to correlate your SCVO2 with the lactate. And the same for the lactate. Because, when I look at SCVO2 and also look at lactate, it gives me a good idea. If I see that the, lactate values sometimes can be, so what are the things that can cause an elevated lactate? Every elevated lactate is not, correlating with tissue hypoxia or tissue hypoperfusion. When do lactates go up?
Liver dysfunction and mitochondrial disorder.
So either there is increased production or there is clearance, right? These are the two conditions in which your lactate will go up. So which are the conditions in which there is increased, production, right? So decreased, like I said, could be various conditions, including liver dysfunction or, some conditions like that, where it is not the tissue hypoperfusion, but it's because of liver dysfunction, there's poor clearance, and that is why your lactate levels are high. But you can get increased production, of course, when there is tissue hypoxia and there's poor perfusion, but also in some other conditions. Can you tell me?
Mitochondrial dysfunction.
We're talking about some vasopressors.
High vasopressors.
Which
Specific vasopressor, you will see lactate elevated, and that's why we don't use it for resuscitation.
Dopamine.
Dopamine, no. Adrenaline.
Adrenaline.
Resuscitate, yeah. Adrenaline can cause elevated lactates. Okay, so when you're resuscitating a patient in septic shock, we don't use adrenaline unless it's, a very dire situation. So adrenaline, why does adrenaline cause lactates to rise? Anybody can answer that in the chat? Yes, someone said adrenaline. Okay. But how does adrenaline cause the lactates to go up? What does it do? So it causes accelerated glycolysis, okay? So because of the accelerated glycolysis, there's increased production of lactates. So when you're resuscitating a patient who's in shock and you're using adrenaline, you're not sure that this lactate is going up because of the adrenaline that you're using or because there is tissue hypoperfusion. So you have to be very cautious. So even when you see a high lactate value, don't go on and on giving fluids thinking, I'm trying to clear the lactate, right? So you have to be sure that this is really an elevated lactate because of tissue hypoperfusion. And so in conjunction with SCVO2, it can give you valuable information. So you talked about lactate clearance. So do you know what is the goal? What are we looking at? How much clearance and how much time? There are some studies related to this. So what do we...
20% in 2 hours.
Yeah, 20% in 2 hours. Okay, so the more important than the actual value of lactate is the lac time. Okay, that is the clearance of lactate. But again, this is not very specific, the lactate values. There's a very nice article that's just come in intensive care medicine about how to is this clearance of lactate. You should really read it because it gives you very good insights into hemodynamic resuscitation. It's just published in intensive care medicine. Just last week, I think it has come out. Yeah. So one of the things you could do is, when your lactates are clearing and it will give you some idea because, all that you're doing, all your hemodynamic resuscitation and everything that you're doing, ultimately you're trying to increase the cardiac output. You're trying to, your goal is to improve the tissue oxygenation. So whatever you do, your goal is to improve the tissue perfusion and the tissue oxygenation. That is the end goal of hemodynamic resuscitation. So, I give fluid, the blood pressure comes up. I give vasopressor, blood pressure comes up. I start dobutamine, the cardiac output increases. So what? Has this translated into an improvement in the tissue perfusion, into tissue oxygenation? And that is why to assess this, you need to do downstream parameters. You need to look at the downstream parameters. And these are like your lactates, your SCVO2, because they can tell you that whatever you're doing upstream, is that translating into, you need to have something that can be a mark, tell you that what you're about a performance indicator or something like that, right? So that's where you can look at lactate, but again, take it with a pinch of salt because the values, could be elevated because of some other reasons. But a good way broadly to look at your resuscitation is looking at the clearance of the lactates. And you see, this patient's lactates are clearing, and with your resuscitation, and then you get an idea that if the lactates remain high for a very long time and don't clear, then it correlates with increased mortality in patients in whom it has not cleared. So that's one of the things that you could use as a surrogate. Yeah. Any other marker that you could use when we're talking about doing blood gases? Anything else?
Any other test like where they say mixed venous oxygen saturation,
Yeah.
the central venous oxygen saturation, lactates.
Yes, you could do, which is very, very
Upstream,
useful.
downstream, and macrodynamics, microdynamics, macro
Very
circulation,
few
micro
people
circulation.
use this in clinical practice. Very few. Whereas you have a central line, you have an arterial line. I'm giving you a big hint.
Yeah.
What
So
else do you use? Anybody in the chat? If I have an
you
EG
can
and EG, what can I look at?
add to see the extraction. Yes, there are some.
Someone said that?
Yes.
So you
PCO
can,
gap.
yeah, you can look at the PCO2 gap. Okay. And yeah, so you can do an arterial ABG, you can do a VBG, and you can look at the PCO2 gap. Now, if normal is less than 6, so if it's more than 6, it can tell you that you can improve the hemodynamic status by increasing the cardiac output. Okay. That can, you can, maybe give more fluid or whatever you're considering, but increasing the cardiac output will help you in this situation. So you can very easily look at the PCO2 gap. We do this daily at the bedside in patients with septic shock, especially where you're doing a VBG, you can look at the PCO2 gap, and then there is a scope that you can increase the cardiac output to improve the hemodynamics, rather than just going on giving vasopressors to this. So these downstream parameters tell you about what you can do. Which would you consider now the lactates are 4, and despite what you're doing, it's not going down, and there's, peripheries are still poor, but very cold. Should I start dobutamine on this patient? Should I give dobutamine? Should I? Or in which situation will you consider dobutamine?
If there is any LV dysfunction, contractility, then we consider to add dobutamine.
Dobutamine is an inodilator. So a lot of people used to start dobutamine earlier to improve the microcirculation. But no evidence to do that today. Like you rightly said, if there is cardiac dysfunction associated with sepsis, that is a situation in which you can start dobutamine on these patients. And it's an inodilator. So whenever you start dobutamine, you start at low doses, of course, start with 5 mics per kg per minute, but you will see the blood pressure will fall. So you may need to go up on the vasopressors when you're using dobutamine, right? Yeah, but only if there's cardiac dysfunction. Otherwise, you should not start dobutamine. Yeah. All right. What about other agents, methylene blue, what's the evidence to use them? We're doing a trial with methylene blue. So
Suppose the patient is in refractory vasoplasic state, not responding to all the forms, whichever we thought. It is not uncommon. It do happen in extremely sick patients. Volume status you optimize, try to actually use all vasopressors. Patient is refractorily vasoplasic. So any role of these agents, which has been had a on and off trials, pockets of single case series, which has been reported, methylene blue can be used in them.
Yeah, so it can be used in some refractory shock, but no strong evidence to recommend this, still trials. We're doing a trial at Tata Memorial Hospital using methylene blue. So we're using a lot of methylene blue, but only in the context of trials. Yeah.
So I think Kaladhar and the team, and we also use, again, it's a case, pockets of cases.
And as a rescue, yeah.
And again, as you said, will that translate into the clinical outcome is again a big question. Is it just maintaining the map or a vasopressor?
Yeah.
Versus
this is very important because you think the blood pressure is going up and you're doing good. You think the cardiac you really need to see whatever jugglery you're doing. Ultimately, is it improving your downstream parameters? Because if it's not, maybe that blood pressure is not good enough for this patient. I've increased the cardiac output from 4 to 6, but so what? This patient needs 10. So it is not about just increasing the numbers. It is the cardiac output adequate to meet the needs of this patient who's very vasodilated? So may need a higher cardiac output, right? So all this has to translate into improvement in your downstream parameters, which are surrogates for tissue oxygenation. Yeah. Okay. Sorry. I think I'm speaking.
Some of the comments of nitric oxide selective inhibitor is true theoretically, but translating it into the clinical practice in outcome is now what we are waiting for.
Yeah.
Okay, next slide.
Yeah, go ahead. I think we're taking too long, no?
This is the GRBS trend up to from the time of presentation.
Wow, 537. That was like, really, yeah.
So not about a DKA, but what will be your general target when you are actually correcting the glycemic status in a DKA patient? What will be your our target?
50 to 70 milligrams. Per
And
hour.
lower limit above which you will try to keep?
250, about 250.
If it is dropping to below 250, you will supplement some amount of dextrose.
So it's not that you don't give dextrose at all, okay? Anyway, but Dr. Kola made a very important point. You're not just thinking septic shock, but it could be just infection that's triggered DKA. So it could be a combination of two things. So don't think isolated, okay? So this is a diabetic patient.
So the way ABC got corrected, even the lactate was staying somewhere that. So I think the first component which got rapidly corrected is DKA. I think the other component.
As you rightly said, when you see this kind of dramatic improvement, okay, sepsis will not, get improved so rapidly, right? Because you need to do. Another thing which we missed because we were talking about, imaging and this and that. Always remember that the most important thing in sepsis, and especially when the patient is septic shock, is source control, right? So whatever you do, your antibiotics, your dialysis, or whatever is only supportive therapy. That's all we're doing. So if this patient, I don't know what was this thing, but
4 hours, ma'am. They are in 4 hours. So I think, yes, you are in right point here.
Very important.
The ABC improved. Now I think this is the right time. They should think about it.
Yeah.
Yes, ma'am. Please go ahead. It's the right time. Your discussion is valid here, I think.
So, you're doing, as you said, CT scan or whatever. So when you find something, get the surgeon on board. That's really, really important. Or something you can drain. Put a pigtail and drain it. Because unless you do that, you're just losing time. As intensivists, what we do is we give antimicrobials and we do fluid resuscitation and the output is dropping and we want to do dialysis. We want to give all organ support. But the most important thing in sepsis is source control. Because if, the more you delay the source control, the worse is the outcome of the patient. So if it's a laparotomy, if it's a perforation, if it's something, you need to first address that while you're resuscitating, isn't it?
So in chart, we have seen people suggesting renal replacement therapies, filters and all. Again, re-emphasizing that the first things first, the standard of care first. After your initial stabilization, you look for source control if there is a source which is controllable, treatable, drainable. So what do you think in this case? Your pH looks relatively better from 6.8 to 7.3. What can you do? Your diagnosis, okay, you can come back to your diagnosis then we'll see. You continue your presentation.
After 4 hours, acidosis improved, sir. Patient was clinically better and we allowed the oral liquid diet and urine output is maintaining at 50 ml per hour. And fluid in crystalloid ringal lactate is continued at 100 ml per hour. Antibiotic is given. Injection meropenem 1 gram IV 12th hourly.
Antibiotic is given now after 4 hours?
Loading dose already given at the time within 2 hours, sir.
Within 2 hours. What is the time at which you should be giving your antibiotic if you're suspecting?
Within 1 hour.
As early as possible.
Within 1 hour, it is immediately. And again, remember, they make a distinction now between a patient in shock and just a patient with sepsis. Okay, so if it's septic shock, it's immediate, but they say that you could wait a bit. It's not the patient. Yeah, you could.
Yeah, true. So that I think the 2021 they have given a little relaxation.
So if it's a patient in septic shock, of course you should give immediately. When you say 1 hour, it doesn't mean at the end of 1 hour. It's immediately, right? As soon as you can.
Any reasons? Any reasons? Ma'am is saying septic shock, you should be trying to give it immediately. And in sepsis, you can just maybe take time to evaluate and take a call whether you can give it little later, maybe 3 hours once you are sure. Any reason for that?
Mortality benefit.
Every hour delay in your antimicrobial use, probably will increase your mortality by a significant percentage if you are delaying in a septic shock patient. The same may not be true in a patient there is no septic shock, but the patient is in sepsis and you're still evaluating, you can take a little more time. So that is the reason I think the emphasis is not more onto septic shock patient than a sepsis.
Right.
Okay, your diagnosis is right now? Go ahead.
GRBS is in reducing trend and act rapid infusion is continued, and ABG showed improvement in anion gap and acidosis is improved. This is the
Right. So the numbers are all getting better. You have a blood culture, right?
So blood and urine both grew positive. Okay.
So
And
yes, sir.
on day 1, we could have been done something better. We'll go to this day 5, go to the previous slide. In 4th hour, 5th hour, you're saying patient improved, stabilized, but we could have been something different. Ma'am was repeatedly asking what could have been done better in this case. There was an ultrasound finding of internal echoes in the renal, left renal.
CT was
CTKUB.
CTKUB is done.
Why?
To see the stage of point of infection and
Suppose I have a patient whose ultrasound evidence suggesting there is an enlarged bulky kidneys with internal echoes. What does it gives a clue?
it can be hydroelectronephrosis or it can be pyelonephritis also.
Pyelonephritis with air pockets. What is the diagnosis problem?
Emphysematous pyelonephritis.
Okay, so is this an important component to do something else much before?
So it guides the management.
Source control.
The grading of.
And pointing to what I was saying, that even an ultrasound or whatever you're doing initially, whenever you're managing sepsis, remember whatever we're doing is supportive. First thing, have I tackled the source? Is there something I can do for the source? Sometimes you just have, say, a PICC line, or you have a central line that come from outside, or something, which is a source. Have you taken care of that? Have you removed that? It's really very important because you're just going on treating, giving supportive, management to the patient. But think, what is the source? So like you said, genitourinary system, you've done a screen, you need to do an ultrasound or you need to do a CT or something to see that is there something drainable that I can drain? Or is there some obstruction? Or is there, say, hydronephrosis, or I need to do, PCN? Or I need to do something because that can, the system, right? You can just system. So that's very important because just going on giving antibiotics, sometimes if it's an abscess, the antibiotics may not even reach there, right? You need to have the drainage. So that always keeps source control in your mind, though you may not be able to do it all the time and it may not be necessary all the time. But that's something you need to think of, that where is the infection and is there something surgical that I can do to, or, some intervention that I can do to, for this condition. Yeah. Okay.
Next.
This is the complete urine examination. It showed urine ketones is 4+ and showed pus cells in urine examination, and HbA1c is 8.6. It is poorly controlled. And this is the CTKUB finding.
When is this done and when is it expected?
Sir?
When is the CTKUB done?
Immediate after coming to in the ER, it was done, sir.
Okay, you just kept that lab reports before this, just
yes,
for a comparison.
Yes, sir, for comparison.
Right. So that is a right way to approach this case. So you found a moderate hydroureter nephrosis, emphysematous pyelonephritis. Okay. So what will be your take on this? You have a CTKUB, you have a urine ketones 4+. Initially, you had some stabilization. What next now?
Source control. We have to do source control, sir.
Should have come much earlier, right? In your.
This is guiding the management in emphysematous pyelonephritis. There is a grading, Hunt's grading. It has 4 stages in it. The grade 1, the A4K are pertaining only to the collecting ducts, and if it is pertaining to the parenchyma, then it is grade 2. And grade 3 is 3A and 3B. it is perirenal space, expanding into perirenal space, it is grade 3A, and 3B is pararenal space. And grade 4 is involving bilateral kidneys or solitary kidney involvement.
What is your grade? What you will do here? What is next plan?
This comes under grade 2, sir.
Hmm.
And can be managed initially with antibiotics. And if it is more than 50% involvement of the parenchyma, then we can go for percutaneous drainage.
I have a moderate hydroureteronephrosis.
Yes.
There is
We
an
can go.
obstruction.
Yes, sir, we can go for stenting for this patient. DJ stenting also for this patient.
Yeah.
So is there any urology consult requested?
Yes.
Should take a
Yes.
specialist consultation. And again, you know, the same findings which it also depends on what is the condition of a patient. So you might have these findings in a patient who's absolutely stable versus a patient who's in septic shock. It's very different, right? So if a patient is in septic shock due to this, then that needs urgent attention, right? So the context changes depending upon the clinical situation in which the patient is. And now everything doesn't need surgery because you have many interventional procedures that you could do. But drainage of this is the drainage is very important if you can get the source controlled by that. Yeah. Okay.
Day two patient was improving. Patient was weaned off HFNO support and weaned off noradrenaline infusion. And in human activity infusion was continued. And tolerating oral diet, ABG showed improvement in metabolic acidosis and anion gap is reduced. And blood sugars are controlled on insulin infusion. And patient was planned for left kidney percutaneous drainage in lieu of left emphysematous pyelonephritis.
Yeah.
Okay.
Left kidney percutaneous drainage was done by the urologist, and the fluid was sent for culture sensitivity. Patient was clinically better, and injection long-acting Lantus 18 units subcutaneous was given 2 hours prior to insulin infusion and stoppage, and insulin was changed to fixed dose regimen. And injection human actapid 9 units subcutaneous TID, and injection Lantus 18 units subcutaneous at 10 p.m. was given. On day 3, patient urine culture reports showed carbapenem-resistant E. coli, but patient was continued on injection meropenem as the patient was clinically improving, and ABG and lab parameters were also improved, and drain collected around 150 ml drain flow.
So just for the sake of discussion, what is the reason why you chosen an antibiotic called meropenem in this case?
So the patient is a poorly controlled diabetes and having recurrent urinary tract infections in the past, and we don't know the drug history, what she has taken outside. So,
And she's in shock.
presented in shock.
Even if this patient had repeated urinary tract infection but was not in shock, I would not start with a carbapenem, right? But this patient has had repeated infections and is in septic shock. This is not a patient in which you got to get it right the first time. You cannot just go on escalating because you lose the patient. And she's very, very sick, right?
What are the common organisms you encounter in this community acquired do you think this is a community acquired infection?
Yes, community acquired.
You said this patient had a 2 times admission, and what was the recent admissions? Was the patient used any antibiotic in recent times?
Patient was treated on OP basis, sir.
Any cultures were done? Any antibiotics were used?
History was not given, sir. They told that there was only symptomatic relief and the treatment.
What are the common organisms you encounter or you expect or suspect in them?
E. coli, Klebsiella is most common, sir, and Proteus and Pseudomonas and Enterobacteria can also cause.
Ma'am was pointing out this patient with such a severe sepsis, septic shock, if the patient comes, why do you think you need a carbapenem in this case? What is the rationale for that?
Gram-negative.
It is for gram-negative or some things. With some reason we nowadays, maybe 10 years back, 20 years back, we are not using carbapenems. There were some problems which has led to the use of carbapenem in a sicker group of patients.
Why you the chat?
Anybody else? There is already a comments on the chat box why we use nowadays. Because of increase in the resistant mechanism, and the more common has been ESBL. Okay. And nowadays we are not seeing this uncommon that we also see some amount of resistance to the carbapenem. Suppose the same patient would have been not responded to the
This
first
patient got better, right? This patient was improving, and you were on meropenem, so you're fine, clinically improving. But what would you do otherwise?
Suppose the same patient was on meropenem, and the first day later, half the patient further deteriorates and continues to deteriorate. In spite of your DK getting better, your lactates worsens. What would have been your worries, and what would have been your approach?
From uncontrolled diabetes, there is a risk of fungal infection also, which might be the reason for not improving clinical condition.
Okay. So you wanted to now think about fungus if initial few hours in this patient.
Really?
Yes, CUV will come immediately within few probably hours or an hour or so. Your blood culture flagged, your urine flagged, your pus flagged. I don't know what is the timelines at which they are flagged. And your CUV has hardly any pus cells. It is showing some 5 to 10 pus cells. Maybe there is a complete obstruction somewhere. Okay, so I think the way we would have been approached in this case is first, as we all were pointing out, if I have a source, even there is a sensitive antibiotic, if I'm not controlling the source or draining, it would have been not got better. So day one, we were lucky in this case, it got stabilized. But in situation, if it is not getting stabilized, I will ask probably my surgical colleagues to drain it as early as possible. The second thing I will think about is, am I missing any organisms there? What are the possible missing organisms in this other than a gram-negative bacteria in this?
Gram-positive.
What are
Staphylococcus saprophyticus, aureus, Staph aureus.
and enterococci.
Enterococcus, yes, sir.
These are the organisms which I think about. And as we are talking about XDR pathogens, as your report suggests in this, this is again resistant to the carbapenem. So this patient responded and the report is suggesting it is resistant. What is the inference from this? You're saying the patient had a clinical response and your report is suggesting, I don't know, your clinical response is because of DK or probably.
It may have just been that you resuscitated this patient well, and it was just DK because we had dramatic improvement, right?
Yes.
So how you explain this? You said you continued the carbapenem, maybe, which is a right approach. How do you rationalize that?
Yes, the method of sample collection, we don't. It might not be.
We trust the system, and assuming that the three cultures were positive. If I'm right, the blood cultures were positive.
Yes, sir.
The urine culture was positive. The pus culture were positive. All are positive. So you cannot have errors everywhere and all of them matching.
Yes, sir.
Patient had bacteremia, patient had urine being growing. So we always talk about this in vivo, in vitro variation. Okay. So we do see some of these patients who actually, even though the in vitro tests are showing resistant and so on, a significant improvement, probably we will be watchful. Suppose there is a partial response to them or they are not responding as expected. The other possibility is thinking about the resistant organisms. So what would have been your choice? Suppose this patient responded, not responded, and this report came. What other choice you can have? This patient is responded, that's why you continue. So patient still continues to not respond. What could have been your other choice?
Add aminoglycosides.
Aminoglycoside, why? You have aminoglycoside sensitivity, yes, maybe, but this patient, if it's a septic shock, will you still use a single agent in such a sick patient? What are the other options? So you look at the sensitivity organism antibiotics in there. Will you use, what are the sensitive antibiotics?
Fosfomycin
And
tigecycline.
so which among them will use?
Um,
Will you use tigecycline? So the tigecycline penetration to the urinary tract is extremely poor. So we don't report tigecycline in urine. So it will be confined to intra-abdominal and thin and soft tissue. So probably the only choice which we will prefer is fosfomycin, alternative to amikacin plus or minus. Okay. Fosfomycin has extremely good penetration to urinary tract, and it is a renal protective, and its coverage to E. coli has been extremely good. Resistance to E. coli has shown to be very less. So that could have been another option or a choice in this situation. So this amount of probably knowledge related to the possible organisms, targeting them, appropriate antimicrobial also makes a difference. As ma'am said, along with the supportive care, antimicrobial and source control, these are the two therapeutic options which you are giving to the patient to recover.
And I just want to add, see, of course, there's huge emphasis on source control, but even when you're selecting your antimicrobials, you have to have some considerations. If what is the site of the infection? Okay, what are the, like he was saying, tigecycline may not be a good choice. It's very good for abdominal infection, for skin soft tissue, but not for urinary tract infection. So where is the source of the sepsis? And also, what is your resistance pattern in your hospital? You know, it may not be the same if I'm in a different place. So again, depending upon the level of antimicrobial resistance that you have in your unit, that also will decide what antimicrobial you will start with, right? So these considerations are very important. And the third most important is, what is the clinical condition of the patient? The same thing in a patient who's not in shock and a patient who's presented so sick, my decision for the antimicrobial will again vary, right? So these considerations should be taken into account, and not that for this I have to give this antibiotic, right? It depends on the clinical setting, what is the site of the infection. And of course, I can't overemphasize.
What is the newer antibiotic which can be another option which is not tested here? The newer BLBL which is available. I'm just giving you.
Using it left, right, and center.
Yes.
Ceftrolin.
Ceftazidime-avibactam, the BLBL can also cover Bacteriaceae family, but I will probably need a confirmation from my microbiology lab whether it is sensitive or not. And maybe do I need any synergy?
And Astrinum. Yeah, so a lot of
these are the two options also can be considered. The second question is, what will be my duration?
Right. 7 days, 5 to 7 days. Usually
It is an emphysematous pyelonephritis. As madam said, the correct dose, site penetration, correct duration, all these, and correct organisms cover, all these should be equally important. So what will be the duration? This is an emphysematous pyelonephritis.
If the shock resolves, are you just going to stop the antimicrobials in this patient?
no. Minimum duration is 1 week.
For a pyelonephritis, it will be 2 weeks.
2 weeks.
Minimum of 2 weeks. And suppose the same patient continues to use fosfomycin and continues to remain the same, not improving, remains to be requiring a few mLs of noradrenaline, not taking off, what will be your suspicion? You have already seen a CT. What will be your suspicion? So this is an emphysematous pyelonephritis. It can further worse. You can actually turn into a renal abscess. So it means relook into your source, do an ultrasound, get a CT done. Sometimes it is, as you said, if the grades are upper, you may need to get away by a nephrectomy in them.
Yeah, so this is a very important point when you're managing sepsis and now you know what is your microorganisms and you are on the right antibiotic. Despite that, if you see the patient is actually worsening, you should reassess. You should keep reassessing because that means that the plot has thickened. Something else is going on if this patient is not improving. Like he said, an abscess or something else that needs urgent attention. So source control is not something that you look at once and that's the closed book. You need to reassess because the situation can unfold into something else and some further complications, which again might need source control. I mean, this is especially something you should consider when the patient is not improving despite being on the right antibiotic.
So there were a lot of interest in filters, ma'am. A lot of questions, suggestions that if the patient not responding after all source control, we are lucky this case has a source control, but we will have many situations where there is no source control also. For example, a patient with pneumonia, a patient with bacteremia, you just give antimicrobial. So in those situations, the questions related to filters, ma'am, you can take that question.
Sorry, I didn't
Questions related to filters, the use of filters in septic patients who are not responding. Like you say endotoxin filters, you say cytokine filters.
A lot of people do it. I know it's very industry driven, but there's no strong evidence to really use it. It can be used as supportive care, but one cannot say that, okay, in this condition, your sepsis is going to be better. I think the simple things that you do in treating sepsis are the most important ones, including source control, the correct resuscitation, organ support, and on being on the right antimicrobial therapy. These are just additive things that you can put, but no robust evidence to suggest that
at this point of time, suggesting one filter better than other or filters helping these patients coming out in any large randomized trials. There are pockets of trials which initially were very promising later on when evaluated.
But we don't have any robust data to suggest that this should be the standard of care. No.
So I think we had a fantastic part of ma'am, and we learned a lot from you, ma'am, today.
I learned a lot from this discussion. So thank you.
An amazing experience, and thank you both of you, Swathi and Cherishmanjali.
Very nice discussion.
You have done very well. We do understand when you present a case in front of Dr. Professor Sheila ma'am and senior faculty, it is always not an easy task. It will be easy.
But very well done, and very interesting case also. Very interesting case. It's a very nice case.
And this is again to just give you an overview that how the questions can be pulled across. The case was straightforward, but the questions can be so wider. So these are all the point of discussion.
And, I just want to leave you with one thing that, whenever you're in the exam, you will already know what is the diagnosis of the patient. You'll already know. And you may have access to the file and the notes and everything. But, that is, in a way, it's good also and it's bad also. It's good because you know what you have to know, what kind of questions you'll get. But it's bad because you tend to get biased and you tend to move your entire history, clinically, everything in that direction. So I just want to say, be very broad, and whatever you do is not right or wrong. Try to rationalize why you're doing this, why you're thinking like this, and, move towards from a broader, this thing, narrow down to clinching your diagnosis rather than moving into one system and saying this is this. Like this was a patient, DKA, septic shock. It's probably a combination of the two things, not just one thing. So that's something that you should keep in mind.
In real time, we see more of combinations than a isolated shock. As rightly pointed out, ma'am, this patient had a DKA, volume depleted along with some sepsis. We also see patients with severe sepsis with some cardiomyopathy causing both. So we always see in clinical practice in real time, we always see an overlap. We always see a mix of pictures.
Yeah, even the shocks could be mixed. And you see also quite a dramatic improvement. So there was an element of, you wouldn't see sepsis getting, treated in a few hours. So there's a combination of both the things, I'm sure. Otherwise, someone with 6.8 pH with just septic shock would be someone who would, is really going to die, not going to survive with source control is not done and resuscitated.
We had a couple of 100 viewers and there were a lot of enthusiasm. I think initial half, the chat box was not active. I think later on, there were a lot of enthusiasm. There were many messages to me that chat box is not active. We are not able to interact with ma'am. So it's a lot of enthusiasm. We had 100 logins till now. Thank you, ma'am. We reach around 4,000 to 5,000 viewers in a day time because of all your participation, senior faculty coming, spending their time from their valuable schedules. and enriching the knowledge to all the students, ma'am. It's an honor for us to have you on board, and thank you so much.
Thank you. My pleasure to be with you. All the best to all of you. Thank you very much. Thank you, Sheila, for having me.
Thank you, Kaladhar.
Thank you. Thank you.
Over to you, Kaladhar.
Thank you, ma'am. Yeah.
We
Thank you,
conclude the
Swathi.
session. Thank you.
Yeah, it was very elaborative and informative session, ma'am. Yeah, definitely very good. I think almost 200 people logged in, and really very happy to have you. And thank you, Swathi and Cherishmanjali. Thank you, sir. Venkat, sir.
Thank you.
Thank you, sir. Thanks.
Thank you. Good night.
Good night.